I'll leave the floor for you, Dr. Emad.
Thank you so much, Marwan. It's really a very warm introduction, and I thank you for it. And I'm really delighted to be with you all. I would have loved, and we thought we had planned at some point to see you in person and see you in front of me. But things are what they are, and you know, thank God we have the technology to still bring us together, and I imagine you sitting there in front of me. So I want to wish you all Ramadan Kareem to start from the heart. And as Marwan mentioned, you know, I talked with Dr. Hind, who I thank her for the invitation also, that it will be a CTR style, which is, you know, a number of cases, and we go through the case, and there is always something to learn from every case, and without really going through the didactic of the subject as a whole lecture for every subject, but to learn some messages from every case. And if you have any questions, I guess you can, you know, maybe in between cases or every couple of cases, I'll solicit, if you have questions, you can type them and Dr. Marwan will see them. Or I guess you can request also to speak the question. So without further delay, I'm going to share my screen, and you will confirm to me that you are seeing it. Can you see my screen there?
Yes, it's clear, Doctor.
Okay, very good. So, like every presentation, we have to say about financial relationship, none to disclose. Sorry, let's move. Yeah. So this was a couple of months after I arrived in Abu Dhabi. We worked for a few months at the Sheikh Khalifa Medical City. And I was in the operating room one morning when one of the residents came and to show me a couple of OCTs and say, what do we do with this patient? And she presented to me that, let me just, hang on one second. Yeah. So she presented to me that this was a 54-year-old male patient. He's a USA Marine, otherwise healthy. You know, most of the Marines are healthy men. And he presented to her with a rapid onset of decreased vision in both eyes together at the same time of 3 days duration. And yeah, here we go. The vision was 2400 in the right and 2400 in the left. The intraocular pressure normal, anterior segment had no particular problem. And then she showed me the OCTs. And what are we seeing in the OCT? I'm just getting my laser pointer out. That's the right eye and that's the left eye. And you can see that there is a very obvious increase in the thickness of the macular area with very obvious cystoid macular edema. It is so thick that we cannot even see the outer layers, but there might be maybe some subretinal fluid, but clearly cystoid macular edema. Not only in the right eye, but even in the left eye. Here we can see a bit more the details of the outer retina with the cystic spaces more at the outer plexiform and outer nuclear layer, which that's what usually where it accumulates. And so both of the eyes are having cystoid macular edema of rather sudden onset in a 54-year-old man. So you start thinking, oh, maybe bilateral vein occlusion, or does he have a blood dyscrasia? But then you look at the infrared and I couldn't see any hemorrhages. Everything else in the retina looked fine except the macular edema. So when things are not really fitting to what you expect, then you start thinking of, could this be trauma? Can trauma cause something like this? So I told her, did he tell you anything about the circumstances? What happened before and so on? And she said, indeed, he actually reported falling forward from a quad in the desert and landing on both shoulders. So what happens really in such a fall is really a whiplash. So when you have flexion and extension, this is what we call a whiplash. And there is indeed a reported and known type of maculopathy that is called a whiplash maculopathy. And it really happens in both eyes, rapid development of decrease in vision in both eyes. And for those who are caught in the first few days, it's bilateral cystoid macular edema. There are only a handful of reports in the literature, and all of them, one case reported. And I'll show you the follow-up and you'll understand why probably most of these cases go undiagnosed, because 1 week later, here is the OCT of this patient. The massive cystoid macular edema now is much better. In the left eye, in the right eye, we can see here, now the outer layer is much better. And yes, indeed, probably there was some subretinal fluid in the acute phase, but definitely it is much better. And the vision from 2400 is 20/50. And the left eye, also there is a little bit of subretinal fluid and less cystic changes. And the vision here is 20/50. And when you look at the OCTs of 3 months later, much better recovery. And the right eye now is 20/25 and the left eye is 20/30, but heading there to full recovery. All the cases that have been reported in the literature, all the reports that are in number of about 9, have reported a very quick recovery. So not every person getting the whiplash situation gets an OCT, and sometimes they have other problems ongoing, like other types, other traumatic consequences that let people really is more urgent to address, and then they do the OCT later and they cannot imagine the CME that was there only 2 or 3 days after the trauma. So just remember, bilateral massive cystoid macular edema after a whiplash trauma does happen. It is known to occur and it does not need any treatment. It resolves spontaneously within a week. It's very fast. And maybe if we had imaged him even after 4 or 5 days, maybe he would have already been better. He probably would. So just we're gonna move on maybe to this other case, which has also cystoid macular edema, but of a totally different circumstances and totally different diagnosis. That was a 40-year-old male patient. He's known Marfan when he presented to me, and he had many years before had undergone pars plana lumpectomy and vitrectomy, with insertion of an anterior chamber intraocular lens. You can imagine that he probably had dislocation of his lens or subluxation at the time of intervention. And they also did 360-degree laser. The left eye was done in 2002 and the right eye in 2006. Now, Marfan is known to be caused by a heterozygous mutation in the fibrillin gene on the long arm of chromosome 15. He presented complaining of decreased vision in the left eye. He didn't have a problem until about 10 months ago or a year earlier. And he said that he was diagnosed as Irvine-Gass. He brought his report in the left eye and he was treated. It was outside the UAE with multiple injections of ranibizumab. I think he had a total of 3 or 4. Every time he had the injection, he felt like his vision got better, but it recurred. So in the medical history of Marfan, it's also always worth mentioning that those patients, you have to refer them to cardiologists because this is what can put their life in danger. Mitral valve prolapse and then later on dissecting aneurysm. So as soon as you diagnose Marfan, you have to refer the patient to a cardiologist, even if they didn't have any problem. This patient already had cardiac valve surgery many years earlier, and these are a list of medications he was on. The vision was in the right eye to 20/25, in the left eye 20/80. The anterior segment was importantly quiet. There were no cells in this left eye or the right eye. The ACIOL was sitting nicely, and on gonioscopy, it was nicely in the angle. The intraocular pressure was fine. The macula was normal in the right eye, and the left eye is massive. Try to put my laser pointer here. It's massive cystoid macular edema again. And you do see the cystic changes, and it's always more in the outer nuclear and outer plexiform layer. Although here you can see that there are some cysts in the inner nuclear layer and the inner plexiform. And then when the load of fluid is really significant, it can start forming subretinal fluid, and that affects the visual acuity quite a bit. So there are, we will talk a little bit later about the various options that are available to treat Irvine-Gass. It's not only one, and I'm not saying that this is the way to be treated. This is the only way. But because he has had anti-VEGF, and every time he felt that it significantly cleared his vision, so I decided to use anti-VEGF to manage the cystoid macular edema and see his response. His vision here is 20/80 significantly. So on that day, I performed the first intravitreal injection of aflibercept, and he comes after 5 weeks. And the vision is 20/80, and certainly you look at this OCT and it looks worse. The cystic changes are even more than before, and the subretinal fluid is more. But what I want you to also remember is that you always have to listen to the patient. You don't only look at an OCT and take a decision only on the OCT. OCT is very important, but listen to the patient and what he says. Ask him what was his experience, because we know that OCT does not always correspond to what the patient perceives. So he said, my vision was really clear 2 weeks after injection, but then it started blurring again. So on that day, I did the second injection of aflibercept and brought him back a bit sooner. And sure enough, OCT is showing that the profile is better. We're already starting to see foveolar depression. So because the thickness is less, the cystic spaces are less, there is still a little bit of subretinal fluid, the vision is better. And what does the patient say? My vision is definitely clearer. So in this case, you continue this on that line of treatment with anti-VEGF, then you persist with the injection if you are going to go that route. And I did the third injection of aflibercept, and then brought him back, and there were a little bit more cystic spaces, no question about it. The profile is not great, but the subretinal fluid is gone, and that's probably why also he felt his vision to be better. And again, he said, my vision now is continuously improving. So I went ahead with more aflibercept injection, and I'll just fast forward a little bit. Here it is a few weeks later, and the edema is better, no subretinal fluid, vision is improving to 20/40. And 3 weeks later is significantly better, hardly any cystic spaces, no subretinal fluid, vision is getting better. And I did aflibercept number 6 and brought him on the 1st of May, which is 2 to 3 weeks later. And there were no cystic spaces, no subretinal fluid, 20/30. He said, this is as good as I've ever seen. And then from then on, I continued following him, and no injection at that time because we reached our goal, which is to get rid of all the edema. And then you see how it is going to behave. He has had now a total of 6 aflibercept injection. And I'm not going to show you all the follow-ups, but now this is the last follow-up that I had for him, which was a 3 years follow-up. The last was in June of last year. And the vision was 20/30. And the OCT is not showing any edema and no subretinal fluid and no recurrence. Definitely, I have to mention that in cases of Irvine-Gass syndrome, there are really several options. And in this particular patient, for example, you have to think of several things. If he has an anterior chamber intraocular lens, it is important that we look if this lens is sitting nicely in the angle, or is it digging in the iris. Obviously, in this case, you would see some inflammation. He didn't have, but it is something that you have to ascertain when you see ACIOL with Irvine-Gass. Sometimes you have to get the input of the anterior segment to deal with the ACIOL if it is not sitting nice. But in him, it was not causing a problem. Definitely an important therapeutic modality is to use topical steroids, particularly that he has ACIOL. He basically he's an aphakic person, and the penetration is very good. And I have very good experience with difluprednate or Durazole. It is really much more potent than prednisolone acetate. But you have to be careful with the intraocular pressure. And as long as you monitor the pressure, the Durazole is very good. Sometimes subtenon steroids, or and also the use of non-steroidal anti-inflammatory like Nevanac or Ketorolac. Although in massive edema like that, just using the non-steroidal alone is usually not enough. You have to go with something like the steroids topical with Durazole. That's what I usually start with in this particular patient, and I thought I'll share that effect with you. It is reported, aflibercept or even the other anti-VEGF, just for a word to share with you that Avastin is not really used here in the UAE. This is why you will not see me mentioning Avastin. I don't want to say that aflibercept is the only one to be used in this case. There are reports of Avastin, bevacizumab, ranibizumab, or aflibercept in the management of the cystoid macular edema with Irvine-Gass. But you have to be persistent. You have to really follow the patient carefully. And when you reach your goal, you stop and you observe how it is going to behave. Nicely here, it did not recur 3 years later. So this is now, so maybe, with these 2 cases, it is different types of cystoid macular edema. If you have a question or written, typed, or you want to mention before we go to talk about that other case. Are there any particular question? Marwan, do you have any questions, or shall I maybe move on?
Dr. Emad?
Yes.
Yeah, this is Sulaiman.
Hi, ahlan. Good to hear you.
So very great response to anti-VEGF. So now, in chronic Irvine-Gass, what is your first line of treatment? This is one question. Or what are the steps of management in Irvine-Gass, chronic ones that are refractory to treatment? So the second point that I want to warn people about in this case, for example, which is that the use of intravitreal Ozurdex. This is an ACIOL patient that the implant could move forward to the anterior segment and affect the cornea. So keep in mind this when you treat these patients.
Thank you so much. Yeah, sorry.
The third question is, do you have Durazole in UAE?
Yeah, yes, we do have Durazole. That's what I use maybe the most often in cases of Irvine-Gass, cystoid macular edema. We do have the Durazole. It's a very effective drops. So first, I want to thank you for the comment on cautioning against. Totally, I agree with you. It's a total contraindication to use Ozurdex when you have a possibility of the implant going into the anterior chamber. It can damage the cornea. It will have to be removed. It should not be used. So very good comment. Thank you very much, Sliman. To quickly go through in chronic, a patient presenting and he's had, a cystoid macular edema, clearly Irvine-Gass. It's always, a person who has had or let's say most of the cases, they have had surgery before, and you have to really assess the surgery. If the surgery has a particular problem that made him prone to have the inflammation, that generates the macular edema. So like I said earlier, an IOL that is not well positioned, even a posterior IOL that may be rubbing against the iris, various things, if he has had trauma with the vitreous that is into the wound, and so on. So you see what are the things you can deal with, and sometimes I get the input of my anterior segment colleagues, and they say he has more to lose than to gain by removing the IOL because the cornea will suffer more. So I start thinking of then the therapeutic modalities. Basically, most of the time in my hands, it is steroids. When you have Durezol, it's very effective even in pseudophakic patients. Doesn't have to be aphakic. To help it, I add non-steroidal anti-inflammatory and sometimes the subtenon triamcinolone. If the patient does not, is pseudophakic with an intact capsule and so on, you can also think of using intravitreal Ozurdex.
Great, thanks.
All right, thank you. So we're gonna a little bit change of gear, and this was a 43-year-old woman who presented to Cleveland, to our hospital, to one of my dear colleagues, and to whom she complained of decreased vision in the left eye that she discovered accidentally 8 months earlier by chance when she closed her right eye. And you know, she's been kind of hesitating to go get examined, and I wasn't sure. And now she presented being otherwise healthy, but 3 months pregnant. And the vision on that day was 20/60 in the left eye. The anterior segment was normal. And the OCT, I'll share it with you, that on the day of presentation to my colleague, here you can see that the OCT of the right eye is completely normal. There is some vitreous here, but there is no traction at all on the fovea. But this is what we call, what I would label, as long as you see the vitreous is a little bit elevated, then you label this as vitreomacular adhesion. But the profile is pristine; it is not affected. And so it's not it's not a vitreomacular traction. The left eye is definitely a full thickness macular hole. The optos doesn't show us anything special other than, yes, this is a full thickness macular hole. And the vision, as we said, was about 20/60, 20/70. Because of her pregnancy status, because that this has been chronic, she anyway did not want to have any particular surgery, so no surgery was done, with the idea of revisiting as soon as she delivers to then assess. I saw her a year later, so by then it was approximately 1.5 to 2 years of full thickness macular hole. And you can see here, the hole has not changed a whole lot. Maybe I'm showing you the radial scan. Whenever there is something that is with the vitreomacular relationship, it is always good to do the radial scans versus the raster, the horizontal raster that goes up and down, because here you can catch sometimes even very small holes that a raster will miss. But obviously in this case, it is, you cannot miss that. And there are some cystic changes, and this is not astonishing with chronicity. And now the vision is just not very, not much worse, 20/70. And then, you know, her question is, if you do the surgery, is my vision going to improve? She wanted some guarantee of success of improvement of vision. Now, we used in the past, some years back, and some might remember, when the macular hole was more than 6 months, we basically kind of gave up on it. But this attitude, slowly, with the collective experience, has changed. And although this macular hole was reaching to 2 years, said, you know, the person is young and there is a chance of improvement that you will not have without doing the surgery. So we decided together to proceed with vitrectomy, internal limiting membrane peeling, and gas injection. And maybe I will mention here that the size of a hole, you really measure it by measuring the narrowest area, narrowest diameter in the profile of the hole. And when this was measured, it was approximately 400 microns. So it's on the verge, it's not really large hole yet. It's a medium-sized hole. So I just decided to do the straightforward vitrectomy, internal limiting membrane peeling. And the gas was, I used here the C3F8 and positioned her face down. Over the years also, the number of days of face down has significantly decreased. While days in past, we used to position them for 7 days and even more. Now it is much less than that. I usually position the patient for 3 days. I've been doing this for some time. If it's going to close, it's going to close in the first 3 days. That's what the management was. And the whole question was, after those, this long-standing hole, is she going to recover any vision that she will appreciate? And this is her 1 month post-op. And as you can see, the hole closed. And you can already, we are starting to see the external limiting membrane and no outer, no ellipsoid zone yet. The ellipsoid zone is the photoreceptor outer segment, the mitochondrial area in the inner segment, but it shows us the photoreceptor health. So they are not here formed, but you know, maybe you can start to guess them. And what was the vision? I was very encouraged because she already was noticing that it was better. Definitely not the greatest quality, but it's already better. And that was for me a good indication that this lady might continue to recover. And this is something we know with macular hole surgery, that the improvement continues to happen over months and months. So this is 2 months after surgery, and look at the ellipsoid zone. Now it is much more seen closer to the center of the hole. So it's really the photoreceptors are regenerating and recovering function. 2040, that's 2 months. And then this is 4 months. I'll go directly. At 4 months, she was 2025. I think I have 1 year post-op. Interestingly enough is that in the center, although it is closed, there is tissue in the hole, but there is like a remodeling with a loosened area here, but the ellipsoid zone continues very sharp all the way to the edge. And her vision measure 2020, she was very happy with the functional improvement. Obviously, I was happy for her, particularly that with the length of the long duration of her macular hole, we had to tell her that we are not sure how much improvement, and she heard it from other people before. So she was really going to the surgery reluctantly, but it is always worth to close those macular holes, because there is regeneration that happens even after very long duration of the macular hole. So this is the next one is a different problem. It's macular also, but Do the residents or anyone have any comment or question about?
Yes, Dr. Emad. Actually, there was a question regarding the first case. One of our residents asking,
the whiplash?
yeah, is asking about the explanation of the macular edema in whiplash injury.
Yes, I don't think anyone really knows the exact cause. These are rare cases, the ones that are reported, but I'm sure that there are more people getting macular edema in whiplash situation, but it improves so fast that, you know, there is no really obvious explanation, but probably something happens that leads to the blood retinal barrier with that trauma, you know, decompensate. So there is leakage from the vessels, and then the RPE also, for some reason affected by that event, also doesn't pump, both of them. But there is really no definite answer to that question, really.
Yes. Another question from one of the residents is, does patient with macular edema in whiplash maculopathy more prone to develop macular hole in the long term?
Macular hole?
Yeah, macular hole on the long term after whiplash maculopathy?
No, not, this is not a known thing. It's not in my experience either. You know, you can sometimes, after trauma with contusion, coup contre coup, you can get a macular hole, but the macular hole in these cases usually develops in the immediate period. Yeah, I mean, it's identified in the immediate period, but not that this macular edema would predispose the person to macular hole.
Yes. Dr. Abdullah Al-Qarashi would like to ask you a question. Then Dr. Fadwa.
Great, yes. Yes, yes, sure.
Dr. Abdullah, you can...
Yes, is it clear now?
Yes, I hear you very well.
Hi, Dr. Emad, nice to see you.
Thank you so much. Great to hear you, Abdullah. Great to hear.
There is what do you think the cause of the macular hole? I thought that the age is young. She's 45 years old. So it's unusual to have full thickness macular hole in this age group. Was there any cystoid macular edema, epiretinal membrane? Was there any cause for this full thickness macular hole? The other thing, since she's for 2 years, did you thought about inverted island flap since it's chronic macular hole? If you have any experience with the island flap technique?
Yeah, so to answer the first question about what caused it, I mean, it is definitely more common in ladies, but this is really a young age for the macular, youngish age for the macular hole, but it does happen. She did not have, I mean, when you look at the, so when you look at the OCT of her, I'm trying to go back, but when you look at the OCT acutely, there's really no epiretinal membrane whatsoever. You know, I did peel the ILM, but there was no epiretinal membrane on it. You know, the negative staining that you can identify when you use the stain. So there were really no membranes on the surface. I thought that obviously if this was a really large hole, I would have used the flap, but because this looked to me, obviously it's medium size, without really any of the complicating situation of being a large hole that would not close. The only problem here was that the long-standing duration. But otherwise, it's pretty straightforward. So I did not use flap in her particularly, but definitely in other situations, one would consider the inverted flap.
Thank you, Dr. Emad. Dr. Fadwa Al-Adil would like to ask a question.
Assalamu alaikum. Hi, Dr. Emad. Thank you for these interesting cases. I had one comment in regards to the refractory Irvine-Gass cases. I usually use carbonic anhydrase inhibitors such as Diamox, 250 milligrams once a day for a month, and they usually respond pretty nicely with the addition, of course, of Predfort drops and NSAIDs. Do you have any experience with Diamox? We know that carbonic anhydrase inhibitors do improve the pumping action of the retinal pigment epithelium, and it does decrease the intraretinal fluid. And I had encouraging results using them with Irvine-Gass.
Sure. Yeah, thank you for the question, Fadwa. And I have used it in the past. You know, I find the Durazole so effective, although, I mean, this particular case, I managed it for the very special situation. But the Durazole is so effective that I say that, you know, to spare the patient the use of systemic medication. However, yes, no, I agree with you. Carbonic anhydrase inhibitors do help some of these patients with edema. Particularly, I would definitely consider using it if I've used everything in my armamentarium and I don't get really much of a response, or I'm left with some edema that is resistant. Definitely the carbonic anhydrase inhibitor is good to consider using. Definitely, very effective. Yeah.
Great, thank you.
Yeah, sure. It is also good in macular edema, you know, cystic edema that is in dystrophies. I use it even from in the topical form. I'm sure you do also. You know, like there's macular edema in RP, and
Exactly.
some of them do respond well to
Yes.
To some
Topical.
Yeah, topical. Yeah, great. Yes.
Yes.
All right. So this is a patient. The next one is a patient who was referred to me for photodynamic therapy. You know, it just so happens that we have the only machine in the UAE. So when colleagues outside Cleveland Clinic Abu Dhabi think the patient really needs PDT, they refer them to me and my colleagues in the retina department. So this was a 45-year-old woman who was referred for that. She, you know, had central serous retinopathy, followed in a local hospital. It was in both eyes, and they sent her in order to be treated with photodynamic therapy. She was complaining of blurred vision, wavy also in both eyes for about a year. And she was treated in the referring hospital with intravitreal injection of ranibizumab in the right eye with no benefit. So 3 injections, last was a year ago. And then they kept waiting, hoping that maybe things are going to get better. And as they didn't, they sent her for PDT. Vision in the right eye was 20/40. In the left eye was 20/30. Anterior segment was unremarkable. And I'm sharing with you here the OCT of the right eye. And just pointing out to the residents that you can see here. Let me see if I can get my laser pointer. The external limiting membrane here is very visible. Obviously, it's elevated. There is subretinal fluid, but the ellipsoid zone stops, and what do you see here? You see very shaggy appearance. And what is this exactly? These are elongation, abnormal, pathological, elongation of the outer segments of the photoreceptors. And just looking at this without getting history from the patient, you know that this has been chronically present. This is not a central serous that started in the past couple of weeks or even in the past month. And I'm just going to show you the cuts as we go down. This is a bit lower, and you see the subretinal fluid is extending even lower. So really, this was the bleb of subretinal fluid in this area. And I'm showing you this because this is the enhanced depth imaging that shows significant increase in the thickness of the choroid. I'll share with you the fundus autofluorescence. It's not a must really, but it is nice to show and show you that the fundus autofluorescence in chronic cases will delineate to you the distribution of the sick retinal pigment epithelium. So when this has been here for some time, you can tell exactly where the bleb is because of the retinal pigment epithelium being laden with lipofuscin, and that obviously gives more glowing and more autofluorescence. And I looked at the fluorescein angiography that was with her. She brought a good looking fluorescein angiography. And right away, the first thing I see is where is the hot spot? You can see that there is one hot spot here, and there was a second bleb on the autofluorescence. I'm sure you noticed it. And there is a second hot spot. But the one that's affecting the fovea is really this one. How close is this? This is not very close. You know, we look really how far is it from the foveal avascular zone. And here, you know, you have at least 500 microns. So from here to here, that almost coming to 900 microns. So it's not very, very close. So it makes you wonder why not consider doing a regular photocoagulation. Let me share with you the left eye. And the left eye has many of the same findings, except that the bleb is smaller and the same shaggy appearance, which is very characteristic of the chronicity of central serous, chronicity of the subretinal fluid. And those deposits here is the photoreceptors that get detached and they deposit on the RPE. This is the EDI. You can see the EDI here with the thickness of the choroid. If the choroid is not thick, you have to reconsider the diagnosis of central serous in general as a, you know, as a message to pass. And it has to be thick. It is thick in both eyes. If it's only in one eye, you also have to think, am I really dealing with central serous? Question yourself. But thickening of the choroid obviously is very significant in both eyes in cases of central serous. And that's her fundus autofluorescence in the left eye. So there was a abnormal autofluorescence in the center, but also superior. That probably was a bleb that was there in the past and it has reabsorbed, and now she is left with the fluid in the center. Now, the fluorescein angiography of the left eye, definitely this one is a bit close, but how close is it? From the edge of the foveal avascular zone, you're talking about maybe 300 microns. So really from the center, it is a good 400 microns. And I know that the people who referred her were hesitant to do focal laser, that when they never talked to her about it. But in my hands, if there is a leaking spot at a safe distance, it is much straightforward and it gives very good results. If it is definitely under the foveal vascular zone, I mean, we do photodynamic therapy for those. So the message here also that I want to pass to you is a patient gets referred to you for something, you can just take it like this and just do what is there. You have to reassess and see what is really best for this patient. So I basically took the patient after discussion, and I had to convince her because, you know, she said, I'm sent for this so as not to use the coagulation and so on. So I explained everything to her, and basically in the routine that I, and I'm sure most of my colleagues do, I always have the fluorescein angiogram in front of me when I treat the patient. I invert the image so that I have in front of me what I'm exactly seeing when I am treating the patient. And then you follow the vessels exactly as you are reading a map. And then you follow the vessel and say, okay, here should be the spot. And this is exactly where you do your laser. The aim of the laser here is a little bit of grayish discoloration at the level of the retinal pigment epithelium. Most of us use a green laser, and you just aim to the retinal pigment epithelium, try to be exactly in the leaking spot. And in this particular patient, I also, although probably it did not have any effect on her vision, I also treated that other spot that it is way temporal. On her left eye, it was a little bit closer, but definitely amenable to the laser in photocoagulation. And I did the same, and I treated it with photocoagulation, following the map and trying to be just on that. On the right eye, because the distance was safer, I used 100 microns spot size. In the left eye, you know, when you are very close to the center, and I think it's better, and I did use 50 micron spot size and just a little bit of grayish discoloration. And this is 1 month after, this is the right eye, 1 month after the treatment, and you can see that the subretinal fluid has completely reabsorbed. And this is in general my experience with photocoagulation. When you aim it at the leaking spot, you really do get very good results, and rather quickly. I want to show you, this is 2 years after, and it never recurred, and her vision improved to 20/20. But I'm putting here side by side the fundus autofluorescence on the follow-up and the angiogram that I used for the treatment. And I wanted to show you the size of scars that you really do, that this is all you need. You don't need a big laser scars. This is just a couple of spots that were aimed exactly at this spot. And this is what is needed. And this one is on that spot. The left eye, same thing. It reabsorbed. This was 4 months after the focal, and this was 2 years. And let me show you, I don't know if you can see it or not, but what shows the laser effect, I mean, you can barely see it. You hardly can see any laser effect here, but there is a darkness here, and that was all what is needed to treat that spot, and you get rid of the fluid. And it's been 2 years. Obviously, patients with central serous can get other attacks in the future, but that particular spot that you treated at that point is not going to leak again. And maybe for the residents also, I'll mention, and it is important to mention it every time with central serous, is that you have to warn the patient about the use of corticosteroids, because it certainly can trigger an attack or make an attack of central serous much worse. So just from this case is just assess the patient, no matter, regardless of how wise the patient is referred. If it is safe distance, it is very, in your hand, you consider it safe, and this is definitely safe. Photocoagulation gives great results in cases of central serous, and really all you need is very, very faint grayish discoloration that can leave you with very little scar, but it does the effect in stopping the attack and reabsorption of the fluid. This will be another case now. Oh, Hisham, sorry, Marwan, how are you doing on time?
As you wish, Dr. Salah.
Okay.
If you want to go past the time, it's okay with us. Dr. Hassan Dhibi has raised his hand.
Oh, that's great.
Thank you, Dr. Emad. That's great to see you at least virtually. And, and
great
cases. I have comments, if you allow to me, to start
Sure.
with the last case of the central serous. She is a lady, and you saw really clearly the pachychoroid on the OCT with the EDI, which is really one of the mechanisms that could give you the support of the diagnosis. The other thing, even though in the ICG there is dilated deep choroidal blood vessels, so it is really a classical case that to show all the features of the pachychoroids. And the treatment options here, it's really, even though that to look for your a type of modality of treatments which you are looking for the leaking point and using the laser, which is simple, straightforward, rather than to go for photodynamic therapy and the possible side effects of the photodynamic therapy. Regarding to the macular hole, I noticed that the hole size is really encounter the the chronicity in this case. Yes. And I noticed even though in the OCT the rim is not that really fibrosed or thick, which is really its prognostic factors and predictor for the success of the surgery.
Completely.
For the Irvine-Gass, actually I have the experience with the non-steroidal anti-inflammatory, which showed really great result in these cases. The other things that, do you like to do sometimes fluorescent angiography to see how much of the leak in this case is? Because I noticed that when you are giving the aflibercept, it is taking a couple of months to restore the contour of the macula. So did you ask to make the duration is less than usual, or you will couple it with something else?
Thank you so much for these great comments. I have not done fluorescein angiography for this patient, and I will acknowledge that at least on the first visit I would have to be complete to do a fluorescein. But that was a self-pay patient, and it was I had to be judicious on what to do for him. Just for that reason, I only went with the OCT in this case. But it's very reasonable to complete the documentation with the fluorescein angiogram in this case. And obviously, as we can expect, it would have shown the typical diffuse leakage with petaloid appearance, and to just confirm, that this is Irvine-Gass type of leakage. Yeah, but I didn't do fluorescein angiogram in him, but it's very reasonable to do it at least once in the beginning of the workup. Yeah.
Dr. Emad, there is another question from Raed As-Sulami. His question is, what about the use of micropulse laser?
Yeah. I'm not a user of micropulse laser. There are publications the use of micropulse laser in central serous retinopathy. Much obviously less than the evidence that is for the photocoagulation or for the photodynamic therapy. I will not fault a person who tries, but in my books, if a person is a candidate for photocoagulation, as you saw, is simple. Obviously, you have to know what you're doing and follow the map and just do it so as not to cause damage. But we all tackle those cases. And if it is in the foveal avascular zone, photodynamic therapy with low fluence, it's basically half fluence, does have very good results, even in chronic cases. So I personally do not use micropulse laser. Yeah.
I think we also just answered the second question, which is the safe distance from the center of the fovea to perform photocoagulation.
Yeah, I personally think of the foveal avascular zone. Anything that's at the edge of the foveal avascular zone or inside it, I think it is just too risky. If you are 100, 200 microns from the edge of the foveal avascular zone, it is possible to treat this as long as you calm the patient, no movement, and you follow exactly where you're treating. I think it is really safe to treat 200 microns on the laser from the edge of the foveal avascular zone. The thing is that I practiced also at a time when, many of my colleagues have, but maybe for me more, when we did laser for choroidal neovascular membranes, and we had to go do treatment rather very close to the foveal avascular zone. I think it's very reasonable. 200 microns on the foveal avascular zone is a safe distance. Even 100. But less than that, it becomes, then why not use photodynamic therapy, particularly if you have access to it. All right, well, I don't want to keep you very long, but I really want to share this case. This is, I entitled it, "Is This Just Branch Retinal Vein Occlusion?" And that was a 65-year-old man who presented to me here in Cleveland Clinic, Abu Dhabi, complaining of blurred vision in the left eye of 4 weeks duration. He thought he was otherwise healthy. For him, he said, I had no problem, except that he was taking an antidepressant for some time, and it was escitalopram, which is Cipralex. Not known to have other systemic diseases. Vision was 20/20 in the right and 20/40 in the left. 20/40 minus, so it's not very good 20/40. And then this is the fundus appearance of the left eye. And for the quick description for the resident is that you have the blood is mainly sectoral. When you see the hemorrhages in the retina in a sector, you start thinking right away of a branch vein occlusion. That's what gives that pattern of sector distribution. The other thing, obviously, is that you do have this, the appearance of feathery edges to the hemorrhages because they are along the nerve fiber layer, and it gives you this appearance. So, okay, that looks like a macular vein occlusion. Let's do an OCT, and the OCT going through the fovea shows cystoid. We saw other cases, and now cystic spaces that are mostly in the outer layers of the retina, but also definitely some in the inner layer, and then you do have subretinal fluid. So it looks like pretty much a vein occlusion with cystoid macular edema, except that I'm looking there in the periphery and saying, this has nothing to do with vein occlusion. What am I seeing here? I'm seeing large geographic areas of chorioretinal atrophy. And then when you look really here, it looks like scalloped edge in the delimitation with the posterior retina. So I said, this is not only branch vein occlusion. So I asked him about night blindness. Does he have night blindness? He didn't have night blindness. What am I thinking of in this case? I'm thinking of, I have to think and rule gyrate atrophy, particularly that it was in the other eye also. He did not have night blindness, and I still ordered plasma level of ornithine, and it was normal. Let me show you the other. Well, I treated his branch vein occlusion with injection, and a month later it went away. But what was really occupying my mind is the periphery of the retinal periphery and the changes that I'm seeing in the retinal periphery. The edema is getting better. And now look at the fundus autofluorescence, you know, very characteristic appearance of geographic chororetinal atrophy. And then here, all around, you can tell that this retinal pigment epithelium is sick. And the only healthy retinal pigment epithelium is what's in the center, like in the posterior pole. And just if we look a cut section in one of these areas, you can see that this area that is normal, the outer layers, the ellipsoid zone is normal. The area where it is sick but not completely atrophic, you can see that the ellipsoid zone is starting to disintegrate. And then in the area of atrophy, there is no outer layer at all, no ellipsoid zone, no external limiting membrane, and no photoreceptors. So I'll just move on a bit faster to show you that the fundus autofluorescence in the other eye is also showing basically symmetrical appearance. So the fluorescein angiography in this particular case shows it's a window defect where you end up seeing abnormal visualization of the choroidal vessels. And then the late frames of the fluorescein, you do see hyperfluorescence that just because of leakage at the edge of the scar. But this is the angiographic pattern of any scar. That's how it shows. And then you can see the area that is salt and pepper, hypofluorescence. This is the area where there is disintegration, or a little bit of disintegration of the outer, of the ellipsoid zone, and then the rather normal area. This hyperfluorescence in the fovea is because of his edema related to the vein occlusion. So what is really the differential in such a case? It is, you have to think of a dystrophy as a possibility, and the one is gyrate atrophy, but he had no night blindness and it's normal ornithine level. And you can think of choroideremia, although it looks completely different. You don't have the patches so circumscribed in choroideremia. He is 65, he sees very well, he never thought he had night blindness. You know, choroideremia causes blindness much earlier in life. And so it's not choroideremia for sure. So we have to start thinking of toxicity. So one possibility is thyroidazine. He denied using thyroidazine. It doesn't show exactly this picture of chororetinal atrophy that appears like gyrate. The escitalopram looked at all over. Nowhere it has been reported to cause such a change. And Cipralex is a selective serotonin reuptake inhibitor, and it is an antidepressant. It doesn't cause retinal toxicity, at least never reported. The one that causes a similar, exactly this appearance is didanosine. And didanosine is a bit delicate because this is a medication that's used to treat AIDS. or HIV. And he tried to ask in all kinds of ways if he has ever, I know he lived in the United States many years, but it's delicate, the questioning to a certain point, but always a denial of having received treatment with didanosine. But I'm positive that this is what it is, and I'll just share with you that the didanosine is a purine adenine nucleoside analog, and it is a nucleoside reverse transcriptase inhibitor, and it was approved by the FDA as an anti-HIV drug, first as a monotherapy, and then it is part of the heart protocol, or the medication used for the treatment. Part of it is didanosine. So there are 30 years of treatment with this drug, and there are publications on didanosine toxicity, although in our part of the world, maybe we don't see it with any type of frequency. But look, I mean, it's not a lot of reports, but maybe this is the most complete report by the David Saraf group, published in Retina in September 2016. He reported 9 and included 10 that were reported in the literature, and 75% of them were men. The average duration of didanosine treatment was 6 years. And when you look at the appearance of the fluorescein angiogram or the fundus, the color fundus photos, or the autofluorescence, that's exactly how it looks. And they all look the same, with patches of chorioretinal atrophy that are on 360 degrees, and areas of sick RPE in between it and the posterior part of the fundus. And the posterior part, which is, I mean, the macular area, that is the normal part. And in general, patients do not have much of complaints, because the posterior pole is good, and they have good vision, and they do not suffer from night blindness. They just don't feel it. They're not handicapped by it. But definitely, when this is seen, patients should stop using didanosine. So I just wanted to share it with you. It is not something we see often in our area, but it's good to put it in your photographic memory. You might be seeing these cases, and definitely the main differential diagnosis would be gyrate atrophy. This would be the closest to this. But again, as I said, you would have high level of plasma ornithine, and then if you do the genetic testing, you would see the mutation. All right. So sorry, I'll go back to my, so any questions or comments or?
Well, Dr. Susan Neolati, during the last case, was asking regarding history if there is any diabetes or deafness.
No, you know, no systemic disease. Oh, I failed to mention that he mentioned that he is otherwise healthy, but after we diagnosed the branch vein occlusion, we sent him for systemic workup, and that's what you should always do. Either you do some basic workup or you send him for workup, and he was not found to be diabetic, but he was found to be hypertensive. So this was also something really important, because hypertension that goes untreated can cause other problems in the future. So at least we caught his systemic hypertension, but he was not diabetic, and there was no deafness whatsoever.
Right. Did you go back and ask for HIV serology, Dr. Emad?
No. I have to admit it's a little bit delicate, and we talked about, and he did not want any workup in this area. So obviously this is something where you have to consent the patient, to have the consent of the patient, and I didn't have it.
Right. So I think no more questions. Okay, Dr. Osama Alam has a question.
Oh, great. Good evening, Osama.
Dr. Osama.
Hello.
Go ahead, Dr. Osama.
Yes, Emad.
Good evening.
Good evening, sir. I said it's always an honor to learn from you, sir.
Oh, thank you very much. It's so good to hear your voice and to know you're there.
Yes, I'm not dead yet. If I may take you back to the first case that you presented, I had a similar case, a young, healthy military man who had a road traffic accident and an airbag injury. And he presented with extensive edema, exactly more or less like the one you showed. And he refused injections of any vascular endothelial growth factor inhibitors. So I gave him topical steroids and non-steroidals. And there was some improvement. And 3 weeks later, he came back and he agreed to be injected. So I injected him with Lucentis. 6 weeks later, he came with total resolution of the edema. So I looked up in the literature and they said that the cause was because in these cases, what happens is that there is raised intraluminar pressure causing microcirculatory circulatory insufficiency, which cause loss of localized loss of endothelial cells with coagulation and complement activation. Hence the advantage of using the non-steroidal drops and the vascular endothelial growth factor inhibitors.
Okay, I'm not sure if I missed, but did you say it was bilateral or
yes.
unilateral in that patient?
It was bilateral.
Bilateral.
Yes,
yeah.
Sir.
And the vasculature, the vascular tree, all looked good.
Yes, and he's a healthy young man. He was around 45 years old. Military.
Yes. Certainly seen, in the presentation, one can think, obviously with asking a careful history, that it could there be a whiplash maculopathy. I have to tell you that the 9 reports in the literature, as well as my case, exactly the same thing. Very quickly, they reabsorb. There is a resolution without any treatment. So, I don't know if this fits whiplash, but there are so few of them. It can still be whiplash that has behaved like you are saying, Osama. So it could be. Did you do fluorescein angiography?
Yes, and there was nothing really. There were no leakage or anything. Just the generalized, no focus.
Yeah, and no hemorrhages around in the retina or anything like that.
Not at all.
So I'm telling you, the literature is. All of them resolve spontaneously. It can be, it might be worth, studying your case and considering it as potentially a whiplash maculopathy that didn't resolve spontaneously, but that stayed, because not only resolved spontaneously, they all resolved within a week. So, so here it stayed longer. It required a treatment. It responded very well. So it can be interesting to report it. The literature doesn't report anything like what you're saying.
So my question to you, do you think that the whiplash injury could resemble the airbag injury?
Well, the airbag injury is really, there is a direct trauma to the, there is more of a contusion rather than a whiplash. You know, the all traumatic changes that you see in the retina are not, you know, what happens in whiplash, but more of the direct contact of the airbag.
He's a big man, and the airbag only hit his chest. So the external examination of the eye and the retina is normal, no hemorrhages, no.
So it's airbag, you know, because I thought you're saying that the airbag has hit his face, which happens sometimes.
No. Yes.
And, so this is a whiplash. You know, you can imagine that, you know, you get the airbag on the chest, and there is a flexion and extension. Yeah, yes. It definitely could be a whiplash from those circumstances, definitely. Yes.
One last question, Emad. What is the secret of your continuous youth?
Yes, it's your kindness. You're very kind.
Bless you.
Yeah, thank you so much. Thank you. Well, thank you really.
Marwan,
thank you very, very much. Great to hear your voice, and thank you very much, Marwan, and thank you to the residents. I would have loved to see you face to face. Inshallah, we have the opportunities future where everything would allow us to meet in person. But if in meetings or whatever, please reach anyone from Saudi Arabia. Is near and dear to my heart, as you know. And just come and reach out and say, I'm a resident there, or I was a resident and now I'm on staff. And it's always a joy to get to know each other. Thank you very, very much.
Thank you, Dr. Emad. We can never have enough from your wonderful CTRs. We really appreciate the time and effort you put on presenting these cases. Hope to see you soon, inshallah.
Inshallah. And Ramadan Kareem again, and stay safe, everyone.
شكرا دكتور عبود. شكرا دكتور عماد. Thank you.
You are very welcome. مع السلامة. مع السلامة.
الله يعطيك العافية. وشكرا Prof. Marwan والله على moderating this. Thanks.
Thank you very much.
Thanks, Emad. Thank you so much. This is Sausan. And Ramadan Kareem to you and your family as well. Thank you, Marwan. Thank you, Hind. And thank you, everybody. It was wonderful.
Shukran for joining us. Thank you for joining us, Sausan.